All right, we are going to go ahead and get started again, and we're going to conclude with our final talk of the day. My name is Ananth Shenoy. I am an outpatient internist, and I practice in a very geriatrics focused practice. And I get to do really cool things like home visits, and I work with a subset of really medically complicated and older patients. And I think my panel is about 90 to 95% over the age of 70. Uh, and I will be talking to you today about geriatrics. And this is an area, and I'll cover that in a moment, that has a fair amount of representation on the boards. I first want to acknowledge that these slides were originally prepared by Dr. Jeff Wallace, who very graciously allowed me to adapt them to continue giving this talk at this course. And I have no conflicts of interest. Now, if you have questions, please feel free to jump on mic if you feel confident to do so, or otherwise feel free to put a question in the chat, and I will try to tackle them in flow. All right. One of the things that we haven't talked about quite yet, but the ABIM, they actually publish what the distribution of content is for the boards. So we can literally look up and see what the distribution will be, and in fact, subject areas that are covered. So I haven't included the full ABIM blueprint, but if you are curious, you can look that up very easily, just literally ABIM blueprint for internal medicine. And you'll get a large document, about 70 or 80 pages, that goes through content area, like subject by subject, as far as the distribution or weighting of different subtopics. Now, geriatrics represents about 3% of the test. And I will call out that this doesn't mean that 3% of the questions are solely focused on geriatrics, but that is one of the primary points of a particular question with about, again, 3% of the test. One of the things that you can also see is probably by far and away the heaviest covered topic is cardiovascular disease, which is why we've already had a number of talks that have touched on it, and we have several other cardiology and cardiovascular focused talks in the days ahead. Now, what we are going to cover today will be a smattering of different geriatrics high yield topics. This is not a comprehensive review of all the different possible geriatrics topics on the exam. Again, you could look through the blueprints if you wanted to see that in more detail, but these are some of the more heavily tested. So we're going to talk about dementia and cognitive impairment, also talk about the management of agitation. We'll talk about weight loss in an older population and falls, and finish up with incontinence. We're going to go through a number of cases. The answer key is also at the very end. So when you do gain access to the full slide deck, which will be on the course page later this week, you can always jump to the end to see the answers. All right. So for case number one, we have a 76-year-old gentleman, semi-retired, who was an accountant and is coming in complaining of forgetfulness. Their spouse, who helpfully accompanies them, notes that they have a decreased ability to remember names and they've been misplacing items more over the past year. The patient in general has been more irritable and he is aware of the memory changes, but feels like he's getting along just fine. He has continued accounting work during tax season and enjoys some activities and hobbies, including playing cards and attending theater. Past medical history notable for diabetes and well-controlled hypertension. Only takes metformin and hydrochlorothiazide. On exam, really non-focal, and you get a mini mental status exam, which is 26 out of 30 points, and missed a point for the date, and one of the three short-term memory recalls, as well as an error in the interlocking figures. So, first question for this patient, what is the patient's most likely diagnosis? Is it vascular dementia, mild cognitive impairment, Alzheimer's disease, or just normal aging? All right, I appreciate, even at this point in the afternoon after a long day, all of you are participating. If we want to go ahead and, great, I think we can end the poll and share the results. The majority are going with answer choice B, with some picking D. So we're between mild cognitive impairment and normal aging. So let's talk about each of those, which is probably relevant not only to your patient care, but also in your personal lives with family members. So, normal aging, there are definitely changes that can happen with cognition. Um, Generally, it's characterized by really there aren't consistent progressive deviations on testing of memory, but there's some decline in processing speed and kind of depth of recall. And sometimes learning new information can be a little bit slower and a little bit harder. Some of the key points is that this doesn't impact function significantly. So the activities of daily living and the instrumental activities of daily living are not limited or impacted. And generally, there are workarounds like reminders, visual tips, notes, reminders. All of those things can help. So those characteristic of some of the cognitive and memory changes that go with normal aging. In contrast, mild cognitive impairment. And this is actually probably best thought of as um, something in between normal aging cognitive changes and dementia. And if we think about dementia on a continuum, mild cognitive impairment probably can be thought of as a precursor, which carries an elevated risk of progression to dementia. And in fact, particularly for those who develop mild cognitive impairment at an earlier age, there's a higher risk of progression to dementia later in life. Um, Usually, with mild cognitive impairment, it's a memory problem, and we don't have deficits in other aspects of cognitive function, and also generally characterized by no functional impairment. And really, in terms of the difference between this and normal aging, it's more notable changes, more significant changes, but these can be adjusted and worked around, and again, tends to be primarily memory focused. So I think here for case one, our best answer is that this is mild cognitive impairment, which again, I think the majority picked. And I just wanted to comment on why indeed it isn't normal aging. So next question. Which medication treatment has shown some, emphasis on some, benefit for patients with mild cognitive impairment? Is it cholinesterase inhibitors like donepezil, high-dose vitamin E, statins, or Prevagen? And Jay, I appreciate you asking. I'll come to that in a moment. I'll address your question on screen. All right, so it looks like we are favoring high dose vitamin E. Ooh, I am very, very glad that we asked this question. So it's a little bit of a trick question. I did emphasize some benefit. Um, Vitamin E has been looked at, and it really doesn't change the rate of progression of mild cognitive impairment to dementia. Donepezil, at least in an older study, did look like it slowed the rate, although didn't change the endpoint of patients reaching dementia. So in this case, when we think about mild cognitive impairment, um, pharmacologic treatments in general don't have, there really isn't anything great. The cholinesterase inhibitors may slightly change your trajectory, but probably not your endpoint. And really, the things that help best, and again, I think this is really relevant for your own practice, but also for probably friends and family. But thinking about the non-pharmacologic side, the thing that time and time again has been shown to be probably the most significant factor that or change that we can do to help reduce our risk of progression to dementia is physical activity. Basically, getting the heart pumping and getting the muscles moving. The way I explain this to patients, when you are walking or you're doing some physical activity and exercise, not only are you getting more blood flow, but you're also literally working out the brain. The brain has to do a lot of complex tasks to control those muscles. As Dr. Krauss was covering earlier, right, the entirety of our nervous system is involved in locomotion. So physical activity, particularly robust physical activity, has the best data for changing the trajectory and risk of progression to dementia. Other helpful interventions are correcting particularly hearing deficits or vision deficits, but those sensory deficits. Again, the brain needs that signal, that sensory input coming in. And then there probably is a benefit to staying active with things like puzzles and staying socially active and engaged, kind of the mental and the social aspect. Now, I do want to jump to a question that Jay is bringing up. And yes, depending on uh, the patient's educational status, a 26 can be a low normal score versus slightly abnormal. So in this case, the patient is right on the threshold. And because of their memory impairment, without other functional status, but notable deficits in short-term memory. That is why that would qualify as mild cognitive impairment. So, Jay, hopefully that answers your question. When we think about dementia prevention, um, this is what I hope is a hopeful roadmap of things, the advice that you can give not only your own patients, but again, your own family and hopefully for your own life. Probably one of the biggest factors are genetics, and we generally speaking can't control that. But higher educational status also reduces the rate of progression to dementia and reduces your risk of it. Then optimizing cardiovascular risk factors, particularly blood pressure and blood sugar. As I mentioned, protecting that sensory input, particularly hearing, and then staying physically active followed by socially active. And then you really want to avoid the poisons to the brain. I emphasize to my patients that smoking and alcohol are toxic to our brain. And if they want to reduce their memory loss and prevent Alzheimer's, the best thing they can do is avoid alcohol and nicotine and smoking as much as they can. So for this question, and I will say I don't think I think we can be pretty confident this is not going to be a board's question, but really I put it in here to be a teaching point. The treatment that probably has some degree of benefit, with again a heavy caveat of it probably doesn't change the end outcome, would be cholinesterase inhibitors. Also, for those who pick statins, this has actually been looked at fairly extensively, and statins also they don't increase your risk of dementia, but they also don't reduce your risk of dementia, particularly when it comes to Alzheimer's. Now, you may have been thinking about, well, what about vascular dementia and optimizing cardiovascular risk factors and treating those with statins? And that is, I think that is a good thing to be thinking about when we're thinking about patients with mild cognitive impairment and the risk, which is progression to Alzheimer's disease. Statins don't prevent that. That said, if you have a patient who would benefit from a statin using your prevent risk calculator, absolutely a very appropriate thing to do. And then, of course, there is nothing backing up Prevagen other than a lot of advertising. Okay, we're now going to talk about other dementia syndromes. We started with mild cognitive impairment and alluded a little bit to Alzheimer's, but we're going to broaden that. So, question number 3. Your 83-year-old patient has had decreased memory, kind of memory changes over the past year. His spouse relates that there are episodes when the patient doesn't seem to respond at all, just for a few minutes, and then seems to come back and is fine. He has also had a couple of falls this year, and occasionally he sees things that are not there. What clinical feature that's described here is most suggestive of dementia with Lewy bodies? So Lewy body dementia. Is it rapid disease progression, the cognitive fluctuations, frequent falls, or visual hallucinations? Wow, that's a lot of very, very rapid answering. I appreciate that. So it looks like we're largely picking D and probably a misclick for E. So we're thinking those visual hallucinations. And very interestingly, and again, this is, I think, going to be helpful in your clinical practice as well. The most common symptom with Lewy body dementia, which really distinguishes it from the other dementia syndromes, is cognitive fluctuations, those periods when the awareness level is lower. I think I certainly was taught in medical school when they're having visual hallucinations, think Lewy body, which I think is why a lot of us chose that answer choice. However, you can absolutely see visual hallucinations in other dementia syndromes, including in Alzheimer's. And while it is common in Lewy body, it's actually in the minority of Lewy body dementia cases, whereas cognitive fluctuations are the most common symptom at presentation. So, cognitive fluctuations, if you're seeing that on the boards, you should be thinking Lewy body. Um, Falls also very, very common. And of course, the other types of hallucinations we can also see. And then Lewy body, also, you can have some of those movement disordered things related to similar to Parkinson's. So the best answer choice here is cognitive fluctuations. Now, when we think about different dementia syndromes, and when explaining it to patients, probably all of you have had some spiel that you give. Most people have heard of Alzheimer's. It is by far and away the most common etiology of dementia, but there are a number of other dementia syndromes. And ultimately, it probably doesn't make a big difference for our clinical practice when we think about the most common causes of dementia and distinguishing between them. And I will say in my own practice, when working with patients, in particular family members, that can be a frustrating point. Often people want a label, and that can give a lot of It can give a lot of sense of closure and reassurance if we can say, well, this is the type that we're confident you have. Um, but Alzheimer's is the most common. And if you're going to bet, you'd start with Alzheimer's again, most common by far. Uh, Vascular is probably one of the next most common, followed by Lewy body and also frontotemporal and Parkinson's. And then there's a smattering of other less common dementia syndromes. So, with Alzheimer's, which hopefully we all know this is a clinical diagnosis. Now, there has been a lot of work, and there's been a lot of work on identifying other markers, biomarkers, imaging findings, and there are definitely imaging findings that could be suggestive for Alzheimer's. There are biomarkers that show promise, although not at a price point that it all makes sense for wide screening. And other than in very limited settings, mostly clinical studies, do the biomarkers make sense to pursue? So it is primarily a clinical diagnosis. And I would actually want all of us to be empowered as internists to be able to make this diagnosis. We do not need to rely on our neurologist to do this. Dr. Kraus is very, very busy seeing a lot of other syndromes. And if we can handle dementia and the diagnosis of Alzheimer's in our primary care clinics, that frees up our neurologists to tackle more kind of the conditions that they are better suited to manage and utilizing their limited time and our limited neurology resources. So in terms of the diagnostic criteria for Alzheimer's, of course, it involves a significant decline in cognitive function and involves classically at least several domains. So it's not just memory, but it's also language or executive function, perception or attention, and social cognition. So it's different aspects of the brain. In fact, this is a hallmark of dementia syndromes in general. Uh, and one of the other aspects is dementia, and that crossing from mild cognitive impairment into dementia involves interference with usual functions. That is, there's some functional impairment. Alzheimer's classically is insidious in onset, and it has a very gradual progression. This is in contrast, as we know, to other dementia syndromes like vascular dementia, which tend to have fairly notable drop-offs or pretty significant punctuated changes. Now, one of the primary reasons to do a really thorough history and exam and to think about the diagnosis is really to look at other causes. Because when we think about dementia, even though most of the dementia syndromes are irreversible and we frankly don't have good treatments for any of them, we do have a small window to identify reversible dementia syndromes. And those are the ones we really want to catch. That's why you do a lab workup. That's why you do a really thorough physical exam. And that's why we emphasize all the different things that can cause dementia, because if we can find one that is reversible, we're making a tremendous change in a patient's life. So when we think about the reversible causes of dementia, the most common ones are actually drugs and depression, which usually is called pseudodementia. Then there are the ones that we learned in medical school. You're thinking about hypothyroidism, B12 deficiency, normal pressure hydrocephalus, then much less common things like a chronic subdural or, of course, a mass or a tumor. And generally speaking, fully reversible cognitive impairment or dementia syndromes are really rare. Again, it's less than 1%. But when you have one of those, you really want to catch it. And of course, that's a diagnosis that is life-changing. Some of the clues that might suggest we're dealing with something reversible, both in your own practice and on the boards, shorter time frame with a more abrupt onset, if the symptoms are more on the mild side, and generally if it's presenting at a younger age. Again, that's kind of a red flag to say, well, could be something else. Now, when we look at cases of potentially reversible or suspected reversible causes, still most of the time it is Alzheimer's and vascular. And it's really maybe 1 in 10 where we find a reversible or potentially reversible cause of dementia. And generally the actual reversible, as I mentioned in the last slide, is probably 1% or less. So rare, but when you can, it's a big deal. When you're thinking about what those are, think about the 3Ds. So drugs, depression, and then a coexistent disease. Um, and with drugs, there is a wide, wide range. And we'll have a question where we'll talk about that in a moment. Uh, and then depression really have a threshold for treatment, thinking about a trial with an SSRI or another appropriate agent. Because again, if you get some benefit and improvement in cognition, that is a huge win. And often when you do have a reversible cause, you can see improvement with a reduction in medications or identifying some other coexisting medical disease that you can treat, or of course, treating the depression. So to highlight this, for our next question, and we're also going to start thinking about agitation, we have a 86-year-old patient who has a history of moderate Alzheimer's disease, and they live in an adult family home. And unfortunately, they've been having increased agitation at night, including striking at staff and yelling. Now, in my practice, this is a very, very, very common scenario. So which of the following would be the least appropriate um, choice? And of course, on the boards, there will be questions structured this way in terms of what would be the least or the worst possible answer. So is it start quetiapine before bedtime? Is it assess for untreated pain? Is it assess for an infection? Or start sertraline before bedtime as a trial? All right. It looks like we are torn between starting quetiapine as the least appropriate versus starting sertraline. And I'm glad you're catching on we want to be cautious with medications. So when we think about agitation in dementia, which I would be shocked if everybody here hasn't managed multiple cases of this in the hospital. Um, but with agitation, antipsychotics should be your last resort. We have a lot of evidence to show that they increase mortality, increase the risk of bad cardiovascular outcomes, increase the risk of falls and fractures. So they really have to be your last resort. And not surprisingly, usually patients are agitated for a reason. And usually, and this is what I explain to families and to caregivers, because of the dementia, they can't express themselves. They can't express an unmet need or some symptom. And this is their way of trying to convey that they are in distress. So our role is to think about, well, what could be causing that distress that they can't explain, that they can't vocalize? So you want to think about pain, you want to think about infections, and again, you want to think about depression. It can be very, very depressing to recognize on some level that your body is changing and failing you, and you're in a situation where you don't have the same agency you used to have. And in terms of clinical practice and for the boards, often the right answer choice and questions are like this are to say, look for other things like untreated pain and work to teach either the caregiver or the staff to look for some other unmet need. Think about, are they thirsty? Are they hungry? Is again something else happening? So for this question, again, I like how everyone was thinking. We want to avoid medications. And really, you're looking between, well, do we have any indication for sertraline versus quetiapine? And again, where we can, we do not want to use antipsychotics. So the antipsychotic is worse than the SSRI. So hence why starting quetiapine would be the least appropriate answer choice here. We are going to continue on this theme in terms of thinking about frailty and decline. So we're going to talk a little bit now about weight loss in older adults. This is defined as a greater than 5% loss of body weight over a period of 6 months or more. And it's actually quite common. So in elderly outpatients, the incidence can be as high as 5 to 15%. And you want to start by actually confirming the weight loss. Again, am pretty frequent in my clinic, and I work with a geriatrics heavy population where the perception of weight loss, particularly by family or caregivers, may not always be accurate. So it is really helpful to literally get the weight and compare it to a prior weight in the chart where you can. So next question in regards to the weight loss in older adults, you have an 81-year-old patient whose weight has fallen from 180 pounds to 162 pounds in the last year. The patient reports a decrease in appetite and just not feeling well. On your review of systems, they do have occasional dyspepsia that they treat with Tums. They do have some constipation. They do endorse not sleeping well and feeling tired during the daytime. They also have some osteoarthritis in their knees, and they infrequently take ibuprofen. When asked about new stressors, he notes his dog died in the last year. What is the most likely cause of his weight loss? Is it non-steroidal induced gastritis? Is it pancreatic cancer? Is it depression or hypothyroidism? All right. So this one you all nailed. So depression. Um, when we think about the most common cause of weight loss, just as you're all identifying, depression for weight loss in older adults, depression is the most common cause, up to 40%. The next most common are gastrointestinal problems, which we'll cover on the next slide. And then less common is malignancy. And I know we're all taught, like part of our brain as internists, we're thinking about those serious systemic illnesses, we're thinking about autoimmune diseases, we're thinking about malignancies, hematologic malignancies. But really, depression and GI problems are more common. And then often it is multifactorial, where it'll be a smattering of these different causes. So, uh, one mnemonic, which ironic, right? We're talking about dementia during this talk, but would be the 9Ds. The most common, of course, for weight loss is depression, as we mentioned. Then the GI ones. So dentition, very, very common issue, dysphagia, dysgeusia, and diarrhea. Then we have diseases like systemic diseases, of which cancer is probably the third most common. Then drugs, dementia itself, which in its end stage can cause weight loss, and then just kind of a gradual dysfunction, usually tied to an inability to get the food due to a combination of limited resources and cognitive changes, and just physical limitations. And then finally, the 10th D, don't know, which about a quarter of the time it is multifactorial and we don't find a clear single cause. So, an algorithm to approach your weight loss. First of all, confirm that indeed there has been weight loss. Next, and it's actually kind of sad, but we want to think about, is there sufficient calorie intake? Uh, and that can sometimes be hard to get at. I have found that sometimes patients, understandably, can be really reluctant to share their financial struggles with their clinicians. And so the fact that they may literally not be able to afford food may be a little bit harder to get at. But really getting a sense and asking, well, what did you have today? And can you walk me through what you've had today or yesterday, what you've been eating this week, or what does your lunch usually look like, and what does your dinner look like? And I also really like asking, and it's a straightforward question, and it's helpful as it's usually integrated as part of your annual wellness exams that you do once a year. But asking, have you had any difficulties getting food or obtaining food, either because of cost or literally being able to go out to the grocery store? Those are all questions that can help you get at, oh, are they not able to get sufficient caloric intake? Now, if they are able to get caloric intake, then you're thinking about, is this a malabsorptive process? And if not, is there an increase in metabolism or catabolism, which can happen from a systemic illness like malignancy? Thinking about endocrinopathies, you're thinking about like the thyroid, and then, of course, chronic infections. Also, many of the really advanced end organ diseases like heart failure, advanced COPD, and emphysema, end stage liver disease, end stage kidney disease can also be associated with weight loss. Now, on the other hand, if they are not getting adequate caloric intake, really you got to think about access to food, which as physicians, we're generally not set up to address. And this is really helpful if you do have a social worker, really helpful to lean on them. And if you don't, it can be helpful to kind of familiarize yourself about what the resources are in your community. Um, then we want to think about, if it isn't an issue of access to food, is it something about their GI system? Is it either an issue with dentition and not being able to swallow? I can't tell you how often that happens with my patients. Um, and if it isn't that, if it isn't an issue with dysgeusia, dysphagia, dentition, then could it be something in the anorexia spectrum due to drugs or depression, or again, things like systemic diseases? So for your evaluation, you start with verifying the weight loss, then you want a really good history and physical. No talk on internal medicine is complete without emphasizing that you need a good history and physical. And then an appropriate, limited, targeted laboratory workup. So it's reasonable to get a UA. Again, you're looking for protein spilling into the urine, and of course, signs of an infection, a CBC, a comprehensive metabolic panel, and then, of course, a TSH, as that's the most common of our endocrinopathies other than diabetes. And it's usually reasonable to get a chest x-ray looking for a mass or some signs of a lymphoma. And really, any further workup, like CAT scans or more advanced lab workup, should really be limited based on any signs or symptoms that you get from your history and physical. And not infrequently, because again, 25% of the chance we just don't know, we end up in this pattern of watchful waiting. I have several patients right now we're just seeing. We've looked for systemic illnesses, we haven't found it, we're treating depression, and their weights have stabilized, and we're seeing, well, will the weight come back, or is it going to continue to decrease at some future point? All right. And then this is just an algorithm walking through that process and what to think about. So for this question, as you all nailed, depression, I think is the best answer choice here. We're going to jump back. We've mentioned depression a couple different times in the setting of dementia, agitation, now with weight loss. So when thinking about antidepressants with our older adult patients, for question 6, you decide this patient has depression based on their decreased appetite, their poor sleep, their increased fatigue. Which of the following would be your preferred medication choice? Would you go with fluoxetine, mirtazapine, bupropion, or methylphenidate or Ritalin? Excellent. All right. So we're between A and B with most choosing mirtazapine. And I will say I think both of those are really, really good answers. And I think for those of you who are favoring mirtazapine, what you're thinking about is it has that sedating effect, and our patient has had difficulty sleeping, and it has that appetite stimulating effect. Again, they've had loss of appetite and the weight loss going along with that. And one of the nice things, so mirtazapine is a quadracyclic drug, and we actually get the sedating benefit and some of the appetite stimulation at the low dose. So you really don't need to go beyond 7.5 to 15 milligrams of it. Um, and it has been looked at head to head to SSRIs. So for those of you thinking fluoxetine, which also generally very, very safe, also a good choice as long as we're looking at medication interactions. Mirtazapine efficacious in older patients, two SSRIs. And if again you're looking for that boost either in help with sleep or appetite stimulation, it's a really, really good choice. And again, you get to go with the low dose with that. So here, mirtazapine, I think, is the better answer choice. But in clinical practice, I don't think anyone would fault you for picking fluoxetine either. So great work, everyone. And I'm glad nobody went with the methylphenidate. Okay, we're going to go, now we're going to jump to falls and hopefully not trip or catch ourselves on something. So for falls, just a couple of quick hitter questions. What percent of older adults fall every year? Is it 10% of our patients 65 and above, 33%, 50%, or 75%? All right. So it looks like we're favoring 33% versus 10%, and those of you who picked 33% are correct. And that's pretty darn common. So 1 in 3 of the patients that you're seeing who are 65 and above have had a fall in the last year. And about half of people who have had falls will have multiple falls. And of course, if you've had multiple falls, you're at risk for further falls. Those recurrent falls are telling you something about their fall risk, of course. It's why fall screening is one of the single most helpful things we can do for our older patients. Because when we can identify factors that we can do to reduce those falls, we can really change their morbidity and mortality. So, why are falls so bad? What percent of those falls result in a serious injury, like, of course, a hip fracture or a vertebral fracture? Is it less than 5% of the time, 10% of the time, 20% of the time, or 33% of the time? All right, we have a nice mix here. Uh, it's a lot of falls that happen. However, thankfully, it's it's less common when it is a serious injury. Of course, if it were very, very frequent that, again, if 1/3 of those patients are falling, and if the majority of those falls were leading to fractures, our orthopedists would be right working nonstop and our hospitals would be full, as would our skilled nursing facilities. Um, but probably the best measure of incidence of how often a fall in our older patient leads to a serious injury, probably somewhere around 3 to 4%. Um, and the minority of those falls actually lead to a medical evaluation. Most of the falls people get a bruise, they pick themselves up, they go about their day. And they may not even think to mention it to you. Again, based on my practice, I can't tell you how often I'll ask a patient, have they fallen in the last couple months or even the last week? They will shake their head, and then their adult child who's with them will be nodding vigorously and will jump in to interrupt and say, yes, you've fallen like 3 times. So often it can just be part of the day to day. But again, if they are falling repeatedly, it is telling you something about their risk. And it really is just a matter of time before one of those falls is going to lead to a serious injury. Maybe about 1 in 20 to 1 in 25 of those. And there'll be something like a broken bone or a subdural or something else really, really bad. So when thinking about what we can do as diligent internists, so injury prevention falls with the number one cause of unintended injury and death in the elderly, and it is the sixth leading cause of death in patients 65 and above. So it's very, very common and goes with a lot of morbidity and mortality. Um, a very strong recommendation, although it's limited in terms of our ability sometimes to make a change in this, but a strong recommendation is that we should be screening for falls. It is one of the pieces that is also involved in Medicare annual wellness visits. For those of you who have not done those yet in your residency clinic, it is just a matter of time before you will be doing those. And basically, it is recommended that at least annually we ask about our patients, have they had a fall in the last year? And if they have, how many falls? And then were there any injuries? So we find out our patient is falling. In this case, we have an 86-year-old. They've fallen 3 times in the last year. They live alone. They're pretty sedentary. Their past medical history notable for diabetes, hypertension, depression, osteoarthritis, some macular degeneration. Kind of everything you would not be surprised to see in an 86-year-old. Their medications, they take glipizide, amlodipine, hydrochlorothiazide, paroxetine, and ocuvite for the macular degeneration. And which of the following then is the most likely to reduce her risk of further falling? Is it physical therapy, a vision assessment, calcium supplementation, or medication reduction? I'm worried I may be gradually putting everyone to sleep. Our participation has dipped a little bit on this question. So here it looks like we are leading between physical therapy and medication reduction. And we all love our physical therapists. I think here both of these are good answers, although one is a stronger answer. So when we think about what works for reducing falls, the most single modifiable risk factor are medications. Uh, where we can, you want to look for withdrawal of medications that are likely to contribute to falling. There are different tools to assess this. The Beers criteria are always useful. There is a more focused tool called Stop Fall, which is focused more on what medications do we think are much more likely to contribute specifically to falling. But essentially, when we look at interventions that are most likely to reduce your risk of falling, withdrawal of medications, high-risk medications, particularly psychotropic medications, those that can affect the central nervous system, has the single biggest impact on reducing your risk of falling. Now, some of the other things, a home hazard assessment and modification, which your home health physical therapist and occupational therapist can do, also can help. Then regular exercise, Tai Chi in particular, has been shown to have benefit. Those are other interventions that absolutely can help. But again, looking at the medications first is the single most impactful thing we can do. Now, the vitamin D, I'm not going to dive a lot into it. In the slides that I will have available to you, you can see some of the data around falls and vitamin D. Basically, if someone's vitamin D is low, it is probably a benefit to replete it. But otherwise, high dose vitamin D does not prevent falls. But depending on the audience you say that in, you might get yourself a very, very long lecture and looking at studies that go back over the last 30 to 40 years. So when we think about falls and reducing the risk of falling, in the clinic, hopefully everybody has done a get up and go. We want to think about a gait assessment. We want to look, do they have a tandem gait? Or are they shuffling? Does it look like they have difficulty picking up or lifting their feet? Then we want to look at medications. Stop fall again is a nice tool for doing this. Next, then we think about kind of broader assess risk factors for cardiovascular causes, thinking about could they have something driving an orthostatic hypotension or an arrhythmia, cognitive impairment, of course, and then Parkinson's disease and other movement-related disorders. And then finally, think about those physical interventions. This is where the physical therapy might be really beneficial. Thinking about is there more they can do for improving their gait, helping push them towards thinking about things like Tai Chi, and then a home safety assessment. So in this case, I think our best answer would be a medication reduction. And for those of you wondering, what are medications here that we'd want to look at? Probably we'd want to think about the paroxetine, followed by the glipizide and the hydrochlorothiazide. Those are all medications that have kind of a greater risk of inducing falls or contributing to falls. Which is not to say you're going to stop them all at that first visit, but it might be worth having a discussion. Can we try paring down the paroxetine, or would it make sense to switch the glipizide to a safer anti-glycemic agent? And similarly with the HCTZ. All right. Um, I have left off a lot of the slides on vitamin D just in the interest of time, but just a quick question. So on calcium and vitamin D, we have a 72-year-old woman who is on a PPI for gastroesophageal reflux, and she's asking for your counseling regarding vitamins. She doesn't eat a lot of dairy and asks your advice on calcium and vitamin D supplementation. So you, being the diligent internist, you're following national guidelines, you recommend she takes which of the following combinations? Do you suggest 500 of calcium with 400 international units of vitamin D, 1,000 of calcium with 400 of vitamin D, 1,200 of calcium with 800 of vitamin D, or 1,200 of calcium with 2,000 of vitamin D? All right, so we are debating between a couple answer choices. It looks like we're favoring overall choice C, 1200 plus 800. And I do think that is the best answer here. For those who are really curious, I've included, Dr. Wallace and myself have included some of the slides that kind of walk through this. Um, there's probably not a need unless this patient has a clear deficiency of vitamin D for a supraphysiologic amount of vitamin D, hence why D is probably not the right answer choice here. But 800 to 1,000 international units of vitamin D a day, very, very reasonable. Similarly with calcium, 800 to 1,200 milligrams of calcium a day is kind of the recommended or the necessary amount. And answer choice C best encapsulates that. All right, we're going to keep on going. Next case, the next question, we have a 78-year-old woman who's seen in clinic with complaints of urinary frequency, urgency, and small volume leakage when she's en route to the bathroom. On a couple of occasions while out of the house, she had large volume incontinence when she couldn't find a bathroom in time. And obviously, these were mortifying. She drinks 4 glasses of water a day to stay well hydrated because she's also heard she needs to do that. Her past medical history is notable for hypertension on HCTZ, gastroesophageal reflux on a PPI, and on her mini mental status exam, she's a 27 out of 30, is college educated, and history and memory loss suggested for mild cognitive impairment. So, question 9, which intervention is most likely to improve her continence? Is it stopping that hydrochlorothiazide? Is it timed voids, oxybutynin, reduce those 4 glasses of water intake a day, or start donepezil, start that cholinesterase inhibitor, and try to help slow down her risk of progression to Alzheimer's disease? All right. So very good. We are favoring timed voids and also thinking about stopping the HCTZ and maybe looking at the water intake. So we'll come back to this. When we think about urinary incontinence, which is a very, very socially awkward condition, it can be deeply embarrassing. It can really lead to patients withdrawing from interacting with the outside world because, again, if they're always worried that they're going to have incontinence when they're out in public, it really makes it hard to want to go out and do that. This is also something in my practice that I hear at least several days a week, either urinary or bowel incontinence, and how it limits a patient from living their life to the fullest. Now, the most common cause of urinary incontinence is urge incontinence, followed by stress. And often, when they have stress, it's often a mixed case that includes an element of urge, and then followed by overflow, and then functional incontinence. And functional is when it's essentially they don't have easy access to a restroom, or their osteoarthritis is so bad it just takes them too long to get to the restroom, which is what leads to the incontinence. Now, we've already done a lot of neuroanatomy today, so I'll ask for just a little more patience. We're going to go through a little bit more of the neuroanatomy and how that contributes to urinary incontinence, because this really informs different treatment approaches and the diagnosis. So, when we think about urge incontinence, it it kind of is one of two pieces. It's either due to a problem with the detrusor, so that smooth muscle in the bladder that causes the bladder to constrict and push out that urine, or it's linked to the kind of an issue with the sphincter. And often, of course, a really incompetent sphincter can contribute to stress incontinence. But usually it is a mismatch for detrusor versus sphincter. And with detrusor, we're thinking about an issue with hyperreflexia, that is, it's spasming or squeezing too hard, or it has some instability, again, causing spasm. When we look at the innervation for this, for the detrusor side, it's primarily parasympathetic fibers, whereas with the urethral sphincter, we're looking at sympathetic innervation. So for detrusor hyperreflexia, usually this is driven by either a decrease in central nervous system inhibition of that reflex arc. It can be age-related or idiopathic, or it can be due to a lesion in the central inhibitory pathways. So you're thinking about things like a stroke, cervical stenosis, or some other spinal cord lesion, or of course, normal pressure hydrocephalus. You can also see the detrusor instability leading to, again, cramps and like unpredictable, like that sort of urge to go. And this can be due to local bladder irritation, things like UTIs, bladder stones, or things like interstitial cystitis. We can also get bladder detrusor hypertrophy due primarily in men with BPH. That is, that bladder has been so used to pushing against that stenotic tight urethra due to the prostate hypertrophy that it has put on a lot of muscle. For urinary urge incontinence, non-pharmacologic approaches are going to be your most effective option. And it's why, for that question, timed voids probably is the best initial intervention we can offer. Now, you can combine these, and in fact, combining a non-pharmacologic approach with a pharmacologic option can be even more effective. You'll get some synergy, but start with the non-pharmacologic side. Again, whenever we can do something without medications and it's effective, we obviously should do that. And as we'll talk about in a moment, the medications do have drawbacks. Now, timed voids, the idea here is literally they plan every 2 or 4 hours they are going to go to the bathroom. They're going to sit down and they're going to try to empty their bladder. And the idea here is both reinforcing their reflex arc and also helping ensure that the bladder is always in a state like that you're emptying it and you're preventing significant pressure on that bladder detrusor. There are more advanced techniques other than timed voids. Another technique is to have patients go into the bathroom when they feel the urge to go, to sit on the toilet and literally to count to 10 before they allow themselves to go, basically to hold their sphincter and try to overcome that bladder detrusor hyperreflexia. Um, you can also have them work with a pelvic floor therapist who's really skilled in this and doing some biofeedback to help. And then also there is a role for thinking about dietary habits. For your patients who are having a lot of bladder irritants, so if our patient in this question was drinking a pot of coffee a day, which of course I'm sure we've all met patients who do that, or who are having a lot of acidic beverages like a lot of citrus, or sodas, other things that are known to be bladder irritants, that could be a real benefit to cutting back. Or if they're simply having super physiologic amounts of water, they're doing 10 to 16 glasses of water a day, that can be helpful to cut back on. And then, as always, we want to think about the other factors that might be contributing to a functional component. Thinking about mobility, is it helpful to bring the bathroom to them like a commode or a urinal? Now, on the pharmacologic side, which again, start with a non-pharmacologic, For the pharmacologic side, we have a lot of medications. A lot of them are cholinergic agents. A lot of them are literally on the Beers list. So we have oxybutynin and tolterodine. We also have some of the newer ones like sulfenicin, which tend to have fewer of the central effects, the way oxybutynin has more of the central nervous system effects. And all of them are pretty similar in efficacy. And so it's very reasonable to think about in terms of cost and in terms of side effects. So where you can, getting the less CNS, the less sedating and cholinergic agents. Then the newest class is mirabegron. It's been out for a little while now, 10 to 15 years. The nice thing about this is it really doesn't have central nervous system effects. Kind of thing you have to watch for is increased blood pressure. Now, if you just use medications, you can lead to about a 20% improvement. If you combine it with non-pharmacologic options like we reviewed on the prior slide, you can get a 60% or more reduction in the incontinence. So much, much more effective if we do the non-pharmacologic piece and then add the medications to it. So going back to our question, I think here the strongest answer is a timed void. It would be reasonable after that to look at, well, maybe we can cut back on the thiazide diuretic and look at a different agent for the hypertension, and then potentially, if we need, looking at the oxybutynin. All right, we are almost done. We have another 10 minutes. So question 10, we have an 81-year-old gentleman who's coming to the ED unable to avoid. And in fact, they're even leaking and dribbling, but they're unable to initiate going. He's had some mild dysuria and some nocturia, and he's been managing okay until he had a recent upper respiratory infection for which he took an over-the-counter cough suppressant. Past medical history notable for BPH and hypertension, for which he takes doxazosin. Does have some osteoarthritis, takes some Tylenol and some as-needed tramadol, which is an opiate. On exam, he's able to pass a small amount of urine, but you get a post-void residual after that, and it's a very, very overfilled bladder, chronically so, with 600 cc's. So which of the following is the most likely cause of his symptoms of inability to void and leakage? Is it new use of loratadine, maybe for that upper respiratory infection? Is it an inadequate dose of doxazosin? Is it new use of chlorpheniramine and phenylephrine, presumably for that upper respiratory infection, or an overuse of that opiate tramadol, which can have some anticholinergic effects? All right. Excellent. Everyone is getting this. So you are identifying that answer choice C, the alpha agents, the chlorpheniramine and the phenylephrine, taking for their decongestant properties. So when we think about, again, the physiology of incontinence, we're thinking about the detrusor side of things and also, of course, the sphincter side of things. So is it either the bladder squeezing when it shouldn't, or can the bladder not empty or empties too easily because the sphincter is not doing its job? And so this is an example, of course, of overflow incontinence. And this results either that detrusor is underactive, like the bladder has just been so overfilled for so long, the muscles have gotten floppy, or the bladder has an outlet obstruction, or more commonly, it's both. Generally, men who've been dealing with BPH for years, there's some degree of bladder detrusor hypertrophy, and gradually a buildup of overflow until it finally reaches a breaking point where just the sphincter is too stenotic and the muscle isn't strong enough to force the urine out, and the muscle has gotten floppy because the bladder has gotten so distended from being so overfilled for so long. The diagnosis here, post-void residual, is really the easiest way to do this. You're looking for an elevated post-void residual, and often the patients will have kind of continuous leakage. That's one of the hallmarks of this. They also can have an overlap with urge and stress incontinence. And again, you're looking for that dribbling, and they'll tell you they have a difficult time initiating urination, and often the stream is really weak. Now, what can present acutely or cause an acute worsening? You should be thinking medications. And I think everybody is getting that very clear theme for this talk. You're looking at anticholinergic agents, you're thinking about tricyclics. Opiates absolutely can contribute to this. In the case that I gave you, you were told the patient takes the tramadol sporadically, so probably not enough, but definitely if they were taking it every day, that could absolutely contribute to this. And then antihistamines are notorious agents. I have put a patient into this very situation by recommending antihistamines for an upper airway cough syndrome. It is one of the more memorable cases that I will never forget. You also want to think about neurologic causes, patients with longstanding diabetes, with that autonomic neuropathy, and then, of course, mechanical damage. So, your patients who have had surgery on their back, and of course, if they've had damage to the sphincter from things like prostate surgery, and then, of course, chronic weakness of the detrusor from long-standing BPH. Uh, Also, we want to think about anatomic or outlet obstructions, so things like long-term complications from prior radiation, really severe bladder prolapse, and women who've had prior history of either vaginal delivery or particularly vaginal surgeries or urethral surgeries. And then, of course, men, as I mentioned before, with BPH, particularly if they then started taking an alpha agent. And we want to look at alpha antagonists, of course, for treatment of BPH. Well, generally speaking, with outlet obstruction, you want to look at the cause and try to reverse it. In the case of this patient, we want to look at getting him off that offending phenylephrine. And of course, if there is some anatomic obstruction that can't be relieved, we're going to ask our urology colleagues to help. And you're looking immediately at something like a Foley catheter and then potentially other surgical treatments or other interventions. So, in summary, when we think about urinary incontinence, we want to start by thinking about it physiologically. You want to look at underlying medical illnesses and medications that could be contributing. And then, particularly for that urge, you want to think about behavioral interventions followed by medications. And then, in really refractory cases, there is a role for surgery depending on the cause. And our best answer choice here was answer choice C. All right. Um, so I am going to stop here. We kind of took a whirlwind tour of geriatrics. We talked, of course, about dementia and mild cognitive impairment. We talked about fall risk. We talked about incontinence. And just keeping in mind, and also with weight loss, thinking about being really intentional with your medications and really doing a thorough history and physical. In terms of the boards, one of the common testing points here is recognizing that adding pharmacologic agents often can be harmful, and generally with our older, frailer patients, look to remove medications. So that is kind of the theme that I think everybody here, you really picked up on that, and I want you to keep it in mind on test day.